So here we go. Good afternoon. Welcome everyone to the February edition of the NRTRC monthly webinar. Today we'll be talking about managing pregnancies through telemedicine, but before we go into that, I want to invite you to our next webinar, which will be in April. Our monthly webinar in March will be superseded by our conference. So we won't have one next month, but Dr. Ronald Weinstein will be joining us from Arizona and talking about mobile health applications and different telemedicine applications, what works and what doesn't work, what's good and what's a challenge. And of course, we want to invite you all to join us at our 5th annual conference in Seattle, the theme being Innovation Through Collaboration. It's March 21st through 24th. Registration is open, and you can see a link there on the page that you can go to join us. We really hope to see a lot of you there. For those of you who aren't familiar with Adobe Connect, let me just run through the screen very quickly. We've got a pod that shows who's in attendance and who's joined us, who's really excited, some of us even on mobile devices. Down below that in the web links, we have a link to our survey that we ask you to take that will be helpful to us to let us know what you think about today's webinar, and we'll also let you tell us what you'd like to see as webinar topics. That's really important to us, so please do that survey, and in fact it will be placed on your screen at the end of the day today so that you can find it even more easily. You can also find information about our conference, and we have one video slide today that Adobe Connect doesn't seem to like to work with, play well with other videos, so there's a link there so you can see the video after the webinar is over. Below that, you'll see a file pod which offers you the opportunity to download the slides, Dr. Clark's slides today in PDF format, and get you more information on our conference, which we're selling really heavily these days. The chat pod is where we ask you to put questions concerning the operation of the webinar, the technical issues, I suppose you could say. And to the left of that is the question and answer pod, where we ask you to type in your questions for Dr. Clark. She'll keep an eye on this and respond to questions as she has an opportunity during the presentation. And with that, I'm almost at the point where I can shut up now and introduce our speaker. And oh, I hate this. I pushed the wrong button. Dr. Erin Clark is an assistant professor of obstetrics and gynecology at the University of Wyoming Health Sciences Center since she completed her maternal fetal medicine fellowship at the University of Utah in 2009. She is board certified in obstetrics and gynecology as well as the subspecialty of maternal fetal medicine. She initiated the preterm birth prevention clinic for the Utah Department of Health in 2010. Dr. Clark's current research includes a grant from the NICHD to look at markers of developmental delay in cerebral palsy. Other interests include pelvic floor dysfunction related to childbirth, preterm labor, and telehealth. Specifically, Dr. Clark mentors various other providers through biweekly teleeducation and teleconsultation conferences. So with that, Dr. Clark, thank you for joining us, and take it away.
Thanks very much for having me. One minor correction is that I'm currently at the University of Utah, and one of my developing research interests is in telemedicine and how it can help us to facilitate obstetric care. I mean, one of my favorite topics to talk about is obstetric dogma and how we can translate that dogma into precision medicine and population health and novel telemedicine strategies. So there's a lot of dogma in obstetrics. I mean, pretty much the way that we've been providing prenatal care is the same way we've been providing it over the last 100 years. By definition, dogma is something that can't be changed or discarded without affecting the very system's paradigm. And it's really paradigm shift that we're talking about when we're talking about novel ways to facilitate obstetric care and novel telemedicine solutions. And really, we're talking about how to move the needle forward. How do we go from what we've been doing the last 100 years and do something new and novel with regard to precision medicine and population health and telemedicine in general? So we're going to talk about some examples of obstetric dogma that we are trying to address with our current clinical programs that we'll highlight as we go throughout the talk. So one of them is this idea of traditional regional physician-to-physician consultation systems. So traditionally, physicians, when they need to ask an opinion of another physician, do this in a very regional way. They talk to someone within a very narrow geographic region. And I think we can all agree that there are certainly situations where a physician needs to reach out of that geographic region and can provide better care by consulting with a physician farther away. But the mechanisms to do that we've really lacked until now. And so these consultation mechanisms remain really regional. Another example that we'll talk about is the siloed approach that we have to patient safety and quality initiatives. So we get these, on high recommendations from national organizations to implement patient safety and quality initiatives within obstetrics. One example is obstetric hemorrhage safety bundles. So a bundle of evidence-based strategies to reduce bleeding after delivery. And our approach to implementing these initiatives traditionally has been, within a single department or within a hospital, or at best within a hospital system. And we are really in the very early stages of conceiving how we might roll out these safety initiatives on a much broader level. For instance, how might the state of Utah roll out a postpartum hemorrhage safety bundle in an effective way? And then the third example that we can talk more about if there's interest, and that you'll have some additional information on in a separate slide presentation that I'll give out, is this one-size-fits-all approach to prenatal care. So we talked about the fact that we've been providing prenatal care very much the same way over the last many decades. If you are a low-risk pregnant woman or a high-risk pregnant woman or somewhere in between, you essentially get the same kind of 15 face-to-face visits with your physician. And I think we're starting to conceive of ways that we can take a much more personalized approach for these different populations of pregnant women, and there's some novel telemedicine strategies that might facilitate that care. Okay, so our first example is we're going to talk about how we might move beyond the dogma of regional physician-to-physician consultation mechanisms. Well, if we were going to do that, what would it take? Well, it would take use of an innovative telemedicine technology. And use of that technology would allow us to extend our reach to access rural and remote regions, and to thereby help to address disparities in medical care. In doing so, we might be able to develop a workforce of skilled providers beyond the tertiary care center, and ideally, we would be able to integrate both clinical care and research and safety and quality initiatives into that telemedicine strategy. So I think some of you are aware of the concept of Project ECHO. ECHO stands for Extension for Community Healthcare Outcomes. And the mission of Project ECHO is really to expand our capacity to provide care that's cost-effective and follows best practices and allows us to address both common and complex diseases in rural and urban underserved areas. Project ECHO was conceived of in New Mexico by a physician named Sanjeev Arora, who aimed to sort of address the problem of hepatitis C in the state of New Mexico, but he quickly realized he was charged with taking care of and treating all of the hepatitis C patients within the state, and he quickly realized that the capacity of the tertiary care center in which he worked would be vastly exceeded if he were really to be able to treat all of the people with hepatitis C within the state. And so he conceived of a mechanism by which he would be able to provide consultative expertise to physicians across the state of New Mexico to help them to manage those hepatitis C cases, to extend knowledge to them through didactic sessions, and to sort of create regional experts for hepatitis C all around the state. This model has been exceptionally successful. So not only is it now liver care in the state of New Mexico, it's now used for a broad array of disease processes across primarily the western United States, but even internationally. So it's a model that has really worked very well. There's a really nice video that sort of highlights the concept of Project ECHO in 60 seconds. That link is going to be shared with you so that you can watch it on YouTube. And there's actually, under web links on the right, the video link is now posted. So at the end of this session, you can just go on there and watch it. So please take advantage of that resource to kind of get a better view of what Project ECHO is broadly. What does it look like? This is what it looks like. So in the center is Dr. Terry Box. He's our medical director for Project ECHO and also a liver care expert who spearheaded our hepatitis C and liver care Project ECHOs at the University of Utah. You can see him sitting with his expert team in the middle of the screen, on the large screen. And all the way around, you can see sites that have joined from outside to listen into this session. It's kind of the Hollywood Squares view. You see a subset of sites that's joined. Our current Project ECHO capacity allows at least 40 external connections, so you're just seeing a subset of the sites that are participating. These sites really consist of, these sessions consist of two parts. One is there's generally a didactic session, somewhere between 15 to 30 minutes, that discusses a certain topic. So you're increasing the knowledge of these external providers with regard to a variety of subjects. And the second part is a de-identified case review. So these people around the outside are submitting case forms for a de-identified patient that's discussed among the group, and you get specialty recommendations back from Dr. Box about how to manage that patient. Sometimes people are presented once, sometimes they're presented multiple times. So you can see how this facilitates both learning and individual case management and makes it so that people in the community have a much higher level of competency with regard to management of both common and complex diseases. The next slide shows you a picture of what the presentation looks like. So Dr. Box here is giving a presentation on the effects of interferon treatment on hemoglobin levels. So again, you see everyone participating around the outside and everybody sees the slides in the middle. ECHO is really a model by which you can see on this sort of top line that the cadre of ECHO providers interfaces with a large community-based care team, and that by doing that they reach a far greater number of patients with regard to their specialty knowledge and expertise than they would if it was a single specialist provider interfacing with a single patient, for example, within a tertiary care center. So this allows those tertiary care services, those expert services, to reach a much broader audience. So currently at the University of Utah, we serve several clinical areas. We started with hepatitis C and advanced liver care because those were, again, where Project ECHO started. But we've expanded a lot since then, and we have a Project ECHO for immune disorders of the gut. We have a behavioral health ECHO. We have chronic pain and headache management and genetic services. We initiated the pregnancy care ECHO in June of 2015. You can see among this list there's also ECHOs that specifically gear to trainees. We have multidisciplinary trainees that participate in Project ECHO sessions, and there are some Project ECHO sessions that are particularly geared towards trainees, such as the Med-Peds Residency ECHO. This is the Project ECHO regional map. So this area, the red star is Salt Lake City, Utah, where we're based. The blue area that's outlined on the map is our traditional catchment area. So this is where we see people for referral services at our tertiary care center. This is where they're commuting from. And all the blue stars on the map are where we have existing Project ECHO sites within one or more care areas. So you can see that Project ECHO sort of allows us to expand beyond our already broad geographic catchment area to a much larger area to be able to train providers and influence patient care in a broader sphere. We currently have a diverse array of participating providers, 233 of them to date at our University of Utah Project ECHO site. This includes physicians, advanced practice clinicians, midwives, nurses, and a broad group of interdisciplinary trainees. And to date at our single site, this number would obviously be much larger if we were talking about Project ECHO in toto. We've had 742 unique patients presented, so we're accumulating a large experience with Project ECHO. Some of these patients have been presented more than one time. Uniquely, each Project ECHO specialty has a patient presentation form that's developed for them. So we are able to capture that information from each patient encounter, and we enter it into a database that's secure called REDCap. That allows us to improve our clinical model because we're able to look at outcomes and make adjustments and look at outcomes again. You know, the success of the Project ECHO model in managing diseases like hepatitis C has been published in the New England Journal of Medicine, so this data capture is really vital for informing our process. It gives us also the potential for clinical research. So outside of just sort of reporting and project improvement, it allows us to potentially do clinical research projects in a novel way, including the capacity for clinical trials. So at first glance, when you hear about Project ECHO and the mechanism by which it works, it's pretty clear that it expands the capacity of a tertiary care center or any care center that's participating to provide care. Not only does it expand capacity, but it reduces variability in care because we are promoting and training sites on using evidence-based practices as they emerge. We are increasing rural and remote patient access to specialty care because we're reaching those communities without those patients having to commute into our center, which may be several hundred miles, several hours away. It provides an opportunity for CME, so continuing medical education is offered through the Project ECHO model. We get that CME credit primarily for the didactic portion of the discussion. And it supports both primary and specialty care providers, both in urban and rural communities. And it facilitates the education of trainees who are a typical part of the participating providers. But at second glance, there is even greater capacity for what Project ECHO can do. It is a really novel model that can be extended beyond sort of the care model that I've just described. So for one, through the patient presentation forms that we talked about, it allows us to monitor outcomes. That ability to monitor outcomes and make change and monitor outcomes, again, is really what has been described as part of a future national health learning system. If you have heard of this before, or if you haven't, national health learning system basically involves national collection of data to inform best practice care and moving forward with new models of care. Project ECHO may be a vital component of that. It has the capacity to potentially support broad-reaching clinical trials in a really new and novel way. We're just at the cusp of beginning to conceptualize how that might work. It allows us to apply precision medicine principles and really provide patient-specific care in a new way. It promotes skilled workforce development. So we are training providers in these rural and remote areas to be experts in a given area and to have the support of docs at a tertiary care center in the process. And what we're going to talk about now is sort of a unique application of Project ECHO whereby it might facilitate collaborative patient safety and quality initiatives. So this is our second example of dogma. So we talked about the fact that when we as care centers or care providers are implementing patient safety and quality initiatives, we're often doing it in a very siloed way. These initiatives are not always simple. So, recreating them in a silo has its challenges. And one could conceive of a way that a broader implementation, a more supported system of implementation may be more effective. The example that we started with and that we're going to continue with is that of obstetric hemorrhage bundles. So if we were going to more broadly implement a patient safety or quality initiative, if we take, for example, initiation of the hemorrhage bundle within the state of Utah, it would again take an innovative use of technology. We've got to bring groups of people together over a broad geographic area to address a common problem. We'd need to be able to access healthcare systems across the state. In doing so, we would again address resource disparities among those healthcare systems and hospitals. And again, we'd be developing a workforce of skilled providers. You can see how a lot of the aims that we described for Project ECHO are very similar to the aims that we would need to fulfill to be able to do this broader-based safety and quality initiative rollout. So you need a little bit of background about the problem of obstetric hemorrhage before we see how Project ECHO can help. So we're going to go through some information about the patient safety bundle on obstetric hemorrhage. So the Council on Patient Safety in Women's Healthcare formed a working group that incorporated all of the major women's healthcare professional organizations and said, hey, we've got evidence-based best practices for prevention and management of hemorrhage. We need to put those all together and to roll them out in a bundle so that hospitals who are interested in implementing this process can do so in the easiest and most effective way. Importantly, we know that these bundles work. So we know when hospitals implement a standardized, comprehensive, multidisciplinary hemorrhage program that we see significant reductions in maternal mortality and morbidity. We see increased use of appropriate interventions like medications and procedures. we see less intensive care unit admissions, and we see reduced blood product use, all suggesting that we are more effectively treating hemorrhage and saving women from morbidity if we implement these bundles. So first, obstetric hemorrhage is a really worthy problem for focus on a medical bundle and for a unique purpose for Project ECHO. It is one of the leading causes of pregnancy-related mortality in the US and worldwide. So when a mother gives birth in the developed world, 1 in 100,000 of women still die of hemorrhage. In the developing world, that number is more like 1 in 1,000. So this equates to, on a worldwide basis, 1 woman every 4 minutes dying of hemorrhage. In the developing world, that's more like 1 every 90 seconds. It's a huge problem in maternal health. And importantly, it's the most preventable cause of maternal morbidity and mortality. So if you use timely diagnosis and you apply appropriate resources and you use evidence-based management, you can avert a large proportion of these cases. And that's where the bundles come in, because it is promoting timely diagnosis and use of resources and evidence-based management. The incidence in the United States for obstetric hemorrhage is still 2 to 3%. 2 to 3 out of every 100 of our wives, mothers, and sisters are still dying of obstetric hemorrhage. Most of those deaths occur within 24 to 48 hours of delivery. And really importantly, most of these deaths are preventable. If we do critical case analysis of these hemorrhage cases, 50 to 95% are judged by experts to have been averted by evidence-based care. Approximately 40% of hemorrhages occur in women without obvious risk factors. So, 40% of those who are going to get in trouble walk onto labor and delivery with no signs that they're going to be the ones who have the complication, which for us really highlights the need for system preparedness. Hospitals and hospital systems have to be prepared to prevent, diagnose, and treat hemorrhage. In the state of Utah, our postpartum hemorrhage rate is 3.2%, so it's just a bit higher than that national average. And importantly, we see very marked variation by hospital. I suspect this is not unique to Utah. Some hospitals have very high hemorrhage rates, some hospitals have very low hemorrhage rates. In part, this may reflect our patient population that goes to each of these centers. It may reflect documentation and billing practices within individual hospitals. But importantly, it may also reflect effectiveness of postpartum hemorrhage prevention and treatment. In Utah, hemorrhage was the 3rd leading cause of maternal mortality between 2005 and 2012, which is our most recent data. It falls behind embolism and overdose drug toxicity. Even though it's 3rd on the list, it is absolutely the #1 cause of maternal morbidity in the state of Utah, and arguably the most preventable cause of maternal mortality. If we look at transfusion statistics, Utah's maternal transfusion rate is 2-fold higher than the national average. 1 out of every 150 of our delivering mothers gets a transfusion versus the national average of 1 in every 350 mothers. Now, people are quick to point out that Utah is a unique state. Women tend to have more babies, which means they tend to also have more C-sections, and they have more C-section-related morbidity. But even when you control for those things, the rate of transfusion in the state of Utah remains higher than the rest of the nation, and the question is why? Now, everybody agrees that transfusion is not a perfect indicator. A rate of 0 transfusion is obviously not optimal because it means you're suboptimally treating women who get into trouble. A rate of 10% is similarly obviously too high. So people argue about what the optimal rate is. I think in our situation, we have to be careful to really question why Utah's rate is higher, even when we control for aspects of the population. If we look at the rates over time, this is the rate of transfusion on the y-axis and the years on the x-axis, with Utah's rate in the orange line and the rest of the nation in red. You can see that Utah at best has a 2-fold higher incidence than the rest of the nation and up to a 4-fold higher incidence. And importantly, the postpartum transfusion rate also varies tremendously by hospital. So while larger hospitals are obviously doing more transfusions because they're seeing more patients, the rate of transfusion is much higher at smaller facilities. So if we look at Utah birth certificate data, at those hospitals that do less than 100 deliveries per year, the transfusion rate is 2 to 4%. Whereas those that do more than 1,000 deliveries a year, your last line on that graph, the rate is more like 0.1 to 1.5%. That's a dramatic difference that bears looking into. And while we all sort of argue about what the optimal transfusion rate is and what it means when it varies among hospitals, what we can all agree on is that it is a national quality measure. So transfusion is considered an adverse pregnancy outcome, and a higher than average rate of maternal transfusions may reflect suboptimal prevention and recognition and management. And at the very least, if we know what our hospital transfusion rates are, it can give us some insight into how our facility is performing. I recently talked about this subject to a large group of obstetricians, and it was the vast minority, certainly less than 10%, of physicians knew even a ballpark of where their hospital transfusions rates are and what their postpartum hemorrhage rates were, which makes it really hard to affect process change because you don't know where you're starting. So the issue of maternal mortality and morbidity is certainly not unique to Utah. It is a problem across the United States, and compared to other developed nations, Utah has a much higher rate of maternal mortality. So the Association of Maternal and Child Health Programs launched a 3-year initiative to address the U.S. rate of maternal mortality, and it sought to help states to strengthen their maternal mortality surveillance systems, aka get the right rate and know what it was, to use that data to develop and implement population-based strategies and policy change, and to then hopefully reduce maternal morbidity and mortality within the states. They sought to award 1-year grants to individual states, and they sought states who came into this process with a vision. They wanted states to have identified a key maternal mortality issue for the state. They wanted them to identify a population-based strategy to reduce mortality. For the state of Utah, our key maternal mortality issue was obstetric hemorrhage, the most preventable cause. And our population-based strategy was OB obstetric hemorrhage bundles. We got the grant in the Utah Department of Health, was awarded the grant in 2015, and our unique challenge was to figure out how to implement a quality and safety initiative on a statewide basis, which of course is how Project ECHO came in. Now, the goals of Utah's Every Mother initiative are to assist delivering hospitals in implementing or optimizing the patient safety bundle on obstetric hemorrhage that we referenced, and of course the ultimate goal of reducing the rate of obstetric hemorrhage and its associated morbidity and mortality. We felt that with those aims that Project ECHO was really critical to achieving our goal. So what happened with the Every Mother initiative is that we ended up inviting all of the delivering hospitals in Utah to participate in the project. Those who participated, and there were over 25 hospitals in the state, we met together for a day-and-a-half kickoff meeting in October of 2015, and since then we have been in communication twice a month with ECHO sessions that will last 6 months and actually wrap up this spring. So twice a month, we were meeting with these sites and helping each individual hospital and hospital system to analyze and implement each component of the obstetric hemorrhage bundle. We're due to wrap up this spring with a final on-site meeting. Now, if you look at what these sessions look like, they look very much like a traditional ECHO session. So in the middle, you have our didactic presentation, which is addressing the recognition elements of the bundle. And you have the participating sites, again, sort of around the outside. So these are hospital sites and nursing representatives from around the state of Utah who are listening in and learning how to implement the bundle at their individual site. And this is sort of a view of what the discussion looks like with sites that are joining from all around. Now, we had talked before about the fact that, the model for Project ECHO was a didactic portion followed by de-identified case review. Well, this is a little bit different because we don't have specific cases. What we have are a didactic portion that lasts about an hour that covers a specific element of the bundle, and then a large Q&A session where people talk about how to optimize the bundle and give specific case examples of how things are working or not working or could be optimized. We're going to be able to look at several outcomes after this initiative wraps up. One is we have developed pre and post questionnaires to assess process change. So how effective was this Project ECHO model in helping healthcare systems to implement the bundle? We're going to be able to assess at a hospital, healthcare system, and state level how people are doing with regard to hemorrhage preparedness and their compliance with all of the myriad of elements within the obstetric bundle. And then we're going to be able to prospectively track at those levels the hemorrhage and transfusion rates across the state of Utah. This is something that might seem intuitive, but nobody has done this before. So individual hospitals have shown that if they implement the bundle, they see an improvement in outcomes. Nobody has been crazy enough to tackle this issue on a statewide level and to say, can we make statewide change in a critical maternal medical issue? It is a huge challenge. 6 months clearly is not going to be enough to see our ultimate goal of reducing hemorrhage and transfusions, but it is a good start. And I think Project ECHO has really been critical to us as a mechanism to put the right people in the room together to get the conversation going. We've had several partners in the process. So the Utah Department of Health was obviously the grant awardee, and they've been really the driving engine for the initiative. We collaborated with Intermountain Healthcare and all the other healthcare systems within the state of Utah. We collaborated with the University of Utah Center for Clinical and Translational Science. They were critical partners because they are the experts in the analytic piece. So they're helping us with the questionnaires, with the data analysis. I've given you one example of a unique telemedicine strategy that's tackling a unique maternal health problem. But I think you can probably start to conceptualize of how this model, using a Project ECHO type system to put the right players in the room across the state or within a broader geographic region, can start to tackle a wide variety of medical issues. Now, there are no outcomes for this type of approach yet. We're really at the early stages, but the hope is that with the Every Mother initiative, we'll at least be able to have sort of a preliminary case report of how this system might work. We're going to spend a little bit of time before Q&A just talking about the one-size-fits-all approach to prenatal care. This is really just going to be an introduction to the topic because it kind of fits outside of the Project ECHO model. And then you'll get some slides that kind of talk about our approach in more detail. So we had talked in the beginning that one of the most rampant elements of obstetric dogma is the fact that we provide prenatal care the same way to everybody. There are exceptions, but in general, everyone gets the same sort of 15 face-to-face visits with an obstetric provider. There are some novel strategies that have been tried, like a strategy called centering care, where women are getting group prenatal care. It's not for everybody. And I think it's important to point out that we have data from large international randomized controlled trials that suggest for the low-risk population, women who've had a baby before, that they do not need as many face-to-face visits as they're currently getting. In fact, as few as 4 or 5 prenatal visits has been found and reported to be safe. The problem is that satisfaction with that among patients is pretty low for reasons that you might be able to figure out. They have less contact with their physician, and that's a source of dissatisfaction. So we conceived of a way of using an innovative telemedicine technology in order to take a novel approach to prenatal care in a low-risk population. This wasn't Project ECHO. This is a HIPAA-compliant, web-based, simple platform that allows a patient to see a physician. And we conceived of a randomized controlled trial where people were sort of divided into their routine prenatal care versus prenatal care that involved 5 face-to-face visits, with the remainder of visits being done by a telemedicine, with the adjunct of a blood pressure cuff and a scale and a fetal heart rate monitor that goes home with the patient. We're just wrapping up that trial now, and we're going to have the results of randomizing 200 women in that system within a month or so. But the satisfaction rates on preliminary data analysis have been really high, so it seems like this may be an effective way to be able to provide prenatal care to women that really allows us to also access rural and remote populations a lot better than we have. I mean, the vast majority of the state of Utah is rural, and a large proportion is under the designation frontier. And if those people want prenatal care at this point, they generally have to drive several hours to receive each of their appointments. At this point, this type of model might much facilitate the access to care that those populations have. In doing so, it will help us to address disparities in care, and there are, like I talked about with our randomized trial, some novel research opportunities. So we'll provide you that handout so you can sort of look deeper into what we're doing, and I'm happy to talk to sites about our specific approach to prenatal care. we're going to be looking for partners in these efforts. With regard to the Project Echo hemorrhage bundles, we're looking for other states to try this similar approach and to see what headway can be made in a different environment. We're looking for sites that might be willing to participate in future prenatal care trials that use a novel telemedicine strategy, because while I think we're going to show that this system works really well in a predominantly Caucasian population in the state of Utah, its generalizability to the nation as a whole has yet to be proven. So we're interested in folks who have a passion for this area as we do, and are very interested in talking to folks who want to partner with us. So I think I'm going to end there and leave some time for Q&A. We can direct this conversation however you want it to go. We can talk more about Project Echo, more about the Prenatal Care Project, or anything else that sort of piqued your interest. The University of Utah is very interested in sort of being on the forefront of personalized prenatal care and quality and safety initiatives, and these are just a few ways that we're really trying to sort of move the needle forward. Does anyone have any questions or topics they want to talk about?
I'll break in now and just remind everyone that the Q&A pod in the middle of the bottom row of pods is where you can ask Dr. Clark questions. So go ahead and type them in there and she'll respond to them. Nadia, go ahead and type your question in. Again, we don't have audio connections for our attendees, so the questions do need to go in the Q&A pod. So if you can just enter them in the line down there, and if that's not working, there we go.
Let's see, I can only see part of the question. There we
go.
Dr.
Clark, if you click on that, it'll open it up.
So you're implementing telehealth for MFM care. So I think what I would comment on, because you asked for specific considerations, is just that there are several ways to do this. So, I mean, the traditional model is to, do a face-to-face telemedicine visit with a high-risk provider, which may or may not involve ultrasound interpretation too, but it's sort of the traditional telemedicine model. I think that is a really good and necessary part of telemedicine for high-risk obstetric care, but there's also sort of a bundle of services that you might consider. So instead of just doing sort of that face-to-face consultation, Project Echo is a nice adjunct. So if you were or had a connection with a Project Echo site, that allows for de-identified case review, much in the same way that we do sort of the casual physician picking up the phone or emailing another physician. And there's an opportunity to sort of address specific topics of interest within your community and to implement care and safety initiatives using this model, even if it's not through sort of traditional Project Echo, if it's just putting people in the room to sort of do, to reach a larger audience with regard to didactics and such. It's a nice adjunct to the traditional telehealth model. If that didn't answer your question, please add it to the Q&A section. So Rick asked, is the blood pressure cuff scale and electronic fetal monitor self-applied? So I'm assuming this has to do with the prenatal care approach. Yes, we sent patients with a blood pressure cuff, a scale, and a handheld Doppler. They were taught how to use them. They used them under our supervision, and then they were able to take those measurements and directly enter them into our patient care portal for our EMR. It tended to work very well. Now, there are more sophisticated ways to do this. You can employ Bluetooth technology, and we're sort of moving that way. But this was just pretty bare bones. Take these tools home, use them, and put the information into the EMR where the physician could look at it and interpret it. I think, it bears emphasizing that when you're trying to sort of change dogma, you're thinking about how to provide care in new ways, especially prenatal care. There's a lot of resistance to change. I think the patients in general, especially through the Prenatal Care Project, were very enthusiastic and ready to take advantage of technology to facilitate their care. Getting providers to do something new and novel was much harder. So even if you're talking about, telemedicine strategy of any kind where a doc has to log in order to sort of see that web-based interface, if there was any sort of roadblock to the traditional care flow, it was difficult. It takes time to make change, and part of the reason that we picked a very, very low-risk population and kept the same number of prenatal visits and just limited the number of face-to-face visits is because it was baby step forward. So I think there's a lot of things with regard to the equipment, with regard to the model for how we did this care that could be a bigger step forward. But when you're fighting dogma, it's baby steps, and this was our first baby step.
If you have any further questions for Dr. Clark, go ahead and type them in.
I'll add just that if anyone wants to have a conversation offline about any of the specifics of what we're doing or in having a partnership collaboration, I'll have Jordan give my contact information to you, Bob, to send out, or in whatever way you think that we should distribute that. I'm happy to send that out.
Be glad to share that information. Rick asks, how about NSTs?
One of my favorite topics, actually. So right now, the prenatal care randomized trial is just using Doppler. But one of the areas that we're really interested in is being able to apply some of these concepts to a high-risk population. So if you look at population management in a higher risk population, you're managing diabetics or hypertensives, the prenatal monitoring piece, the non-stress test in general, has to be considered as part of the model. So if I were to, for instance, manage a patient with hypertension who is in Elko, Nevada, which is a community that's 3.5 hours west of Salt Lake City, in order to really provide her equivalent care, I have to be able to do non-stress tests. There's not always the capability to do that within her home community. So the idea of doing non-stress tests, a test that's traditionally done in a clinic or at home, in clinic or at the hospital, at home, is an idea that we found very compelling. I mean, really, it requires application of that continuous Doppler monitor in the right place and the ability to get a continuous feed so that the NST nurse or provider can be looking at the tracing and making determinations about reassurance. There are some companies who are really working on the ability to do NSTs remotely. There's a company called Airstrip that we've been in contact with that has basically an NST kit that looks like a little suitcase, whereby a woman can apply a monitor. She uses a cell phone or tablet to show the non-stress test testing, which is then uploaded to a cloud, which is then read by our NST nurse and watched by our NST nurse, and then interpreted by our provider according to our usual care algorithms. We have a pilot project where we've enrolled 30 patients who are doing one on-site NST and one home NST. It's patients who have a physician order for twice-weekly non-stress tests. We have just finished enrollment. So our primary outcome is, can we really integrate home NSTs into our care model? Can we schedule them, bill them, look at the tracings, integrate them into the care algorithm? Does it work? I think I can tell you the answer to that is yes. But as far as like the quality of the tracings perceived by our physicians and the satisfaction of our physicians and patients, that still has to be analyzed. The preliminary work that's been done with this type of technology suggests that the tracing is that you get for those fetal non-stress tests is really good. My experience with reading them is excellent. So I think if you think about population management using a telemedicine strategy, remote non-stress tests are going to be part of it. I think there are people working on this, including our center, and I think it holds tremendous promise, both for being able to access those people in rural and remote populations, and also just for the ability to increase capacity at the tertiary care center. So even people who are in our own neighborhood like to do them from home for convenience, and because we're obviously interested in it from a care center perspective because it allows us greater ability to provide that testing for the community. Otherwise, we're very sort of limited to the brick and mortar 4-chair NST model. So I think it has tremendous potential, and we're hoping to have some publications out on the subject within a year. That was a long answer to a short question. Sorry.
So again, I'll just encourage anyone else that has questions to enter them. While we're waiting, Dr. Clark, I want to thank you for joining us. This is just a grand use of telemedicine. We're really happy that you could share that with us today. And it just does demonstrate that almost everything but probably heart surgery can be done through telemedicine. So thank you very much for joining us. And if there are no further questions, Martha, will you share the survey with us, please? We ask all of you to fill out this survey to tell us what you thought of today's webinar, and also to tell us what you'd like to see as a webinar. We're here to serve you, so if you have an idea of something you'd like to see, please let us know, and we'll try to work it into the schedule. And if you want to get in contact with Dr. Clark, let me know. You can come to me through the website, nrtrc.org, or you can call, if I remembered my number. But one way or the other, I'll get you in contact with Dr. Clark. So thanks everybody for attending. Dr. Clark, thank you. Jordan, thank you for setting this up, and we'll see you next time.
Thanks, everyone.
Thanks, Bob.